participants and attendees to the Conjoined, EAPOS, and ISA webinar. First of all, on behalf of ISA, I would like to thank very kindly EAPOS for this very kind invitation to co-share the session. Let me first introduce my co-moderator, Dr. Hala Elhilali, Professor of Ophthalmology at the Cairo University and Director of the Pediatric Ophthalmology and Strabismus Children's Eye Hospital in Egypt, and Vice President of the Egyptian Association of Pediatric Ophthalmology and Strabismus. We have an outstanding list of panelists, highly recognized from different continents all over the world. The subject is very attractive. If I could turn back time based on very interesting clinical cases, and I'm sure it will produce a very nice discussion. There will be a Q&A box to place questions, and in case we do not have time to resolve them all, please go after to look at them. So, Hala, would you like to say some words?
Yes, thank you very much. I would like to thank all the speakers for graciously accepting the invitation to join this webinar. I especially would like to thank Rosario for the key role she played in organizing this. It wouldn't have happened without her. And I will take just a minute. I know Rosario does not need an introduction, but I would like to take the privilege to introduce her. So Rosario Gomez de Liano is a professor of ophthalmology at Complutense University in Madrid. She is currently the president of the International Strabismus Association since 2018. She's also the former president of the European Society Strabismus Association and also the former secretary, financial secretary or secretary treasurer of IPOS. She has numerous, substantial number of publications, and she has received numerous awards, and we are very, very happy to have her with us today. Thank you.
Well, thank you, Hala. So if we stop sharing, and I will introduce the first speaker. It is Dominique Thouvenin, is a good friend from France. He works in Toulouse. He doesn't need also any introduction. He's so well recognized in his country as an excellent surgeon and an excellent experimental strabismologist, and also all over the world. He works in the Toulouse Centre of Ophthalmologie, Rive Gauche, and he has several positions in international councils as ESA and the French Association for Pediatric Ophthalmology and Strabismus. And he will speak on a very special case of binocular vision field restriction after surgery for third Duane syndrome type.
Thank you, Rosario. I'm going to share my screen. So can you see you can see the screen? That's okay. So I would like to thank the Egyptian Association of Pediatric Ophthalmology and Strabismus and ISA for the invitation to share one of my strabismologic nightmares, because it is the subject of the webinar. You know that the perfect surgical cure of strabismus is generally not possible. Then the goal of treatment must be clearly discussed before surgery with the patient. And when the result of our surgery is disappointing, it is generally because we missed something in the preoperative phase. Sometimes it is just because we have not listened enough to the patient's request and did not tune our wishes from surgery between the patient and us. The case I'm going to expose is the reflect of what I said about this with many teachings. So this is an exoduane type 2 with an upshoot, a classical case. The patient is really bothered by the right head turn. I'm going to push this away because I don't see, yeah. He's bothered by the right head turn and the upshoot. He has an X-day of 12 diopters in a primary position, a limited adduction, a nice upshoot of the left eye, and he has a good stereoscopy. So this is an exoduane with abnormal head posture, an upshoot. The patient is asking for surgery. So I propose surgery because it is logical. And I propose simply to and I did perform a left lateral rectus recession of 7 millimeters and a wide splitting to treat the upshoot. In the postoperative period, everything was quite fine for me, with a little exotropia in primary position, quasi no upshoot, but the patient remained uncompletely satisfied. He couldn't really explain why, and we are going to see why exactly. This is the motility charts on the bottom, and you can see that it is better than the preoperative phase. I don't think I really showed you. This is the preoperative charts. You can see that there is a limited adduction, the elevation in adduction, and also there is in the binocular single vision field, there is diplopia on all the right field of vision. And after surgery, you can see that it's quite nice when you look at it, because the motility is centered on the left eye, and the binocular single vision field is quite centered also, but the patient is not satisfied. If you compare before and after surgery, you can see that there is a gain in right binocular single vision field, and there is a gain in left eye adduction. But there is a loss in left binocular single vision field, and there is a loss in left eye abduction. So this is why the patient is not comfortable, because he's lost something in the left part of his binocular single vision field. So although my treatment was satisfying for abnormal head posture and for the vertical deviation, the reduction of the left single vision binocular field related to the loss of abduction was bothering for the patient. You know that there have been upgraded treatments that are proposed for exoduane that aim to improve adduction and upshoot without limitation of abduction. In my case, which was my case, it is the advice is to perform recession of a tight lateral rectus, but not too much to preserve abduction, and with a wide splitting if the vertical deviation in adduction is present. But in difficult cases, in several cases, lateral rectus recession is mandatory but leads to a limitation of abduction, then a global restriction of motility. So it is proposed to perform a transposition of vertical rectus. It helps to compensate the loss of abduction, and the experts propose to do superior rectus transposition if there is an A pattern, or inferior rectus transposition if there is a V pattern. And you can do, in this case, a maximal recession of lateral rectus without having fear of limitation of abduction. Or you can eliminate the lateral rectus with a fixation to periosteum. So in my patient, he was bothered. The situation was stable, and I proposed him to try to improve abduction by performing a transposition of the inferior rectus, because there was a V pattern with posterior fixation. And after surgery began my nightmare. The patient came back with a large exotropia, excyclotropia of 15 degrees, no single vision, and a very bothering subjective torsion. At this moment, I really thought about finding a way to turn back time, as you asked me for. So the situation did not improve with time, and 1 or 2 months after this second surgery, I proposed a third surgery. I removed the posterior fixation and I recessed the inferior rectus, because I think the most bothering problem was the excyclotorsion, and that's what I did. And then at last the patient was happy, I was happy, but there remained the limitation of abduction that remained unchanged after that, but the patient was quite happy. So the first lesson of this case is that the improvement of the motility charts that you see on the bottom satisfies the surgeon, but what is important for the patient is the improvement of binocular single vision field, and it is the reflect of the patient's quality of life. If it is not at the expense of the previous direction of binocular comfort, as it was the case in for my patient. Second lesson is that the best may be the enemy of the good. I think I was right to start with a simple procedure. It was safer, it was predictable, and it was relatively efficient. It was the right answer to the patient's demand because he didn't have any left abnormal posture, I didn't have any upshoots, and I think I should not have tried to do better. With better preoperative explanations and with time, I think the patient would have been satisfied of the situation. And the third lesson is that adults have less brain and muscle plasticity than children, and too much changes in this long-standing CFEOM may be more bothering than relieving in adults. So I think it's sometimes better to be prudent before doing some too sophisticated protocol. I thank you. I'm happy to discuss this case with you.
Thank you very much, Dominique, for this very interesting case. As you said, the simpler the best. And I remember once we did a review about which is the type of strabismus that was least satisfying for the patient, and number was Duane syndrome. Often patients don't understand which is the objective of the surgery, and if the visual field is reduced, as you said, they don't feel the improvement. And sometimes we go for very big upshoots in order to improve those upshoots that we see on the versions, but the patient don't see themselves those upshoots so often. So that was a comment. I also would like to add two things. Here we had two things, an exotropia and a vertical that you wanted to manage. And I remember that from Paulo Sousa, that he said once that whenever you recess a lateral rectus on a Duane syndrome, you will never have enough for correct the case, and you will limitate strongly the abduction. So that's something that we often happen, and sometimes to correct with the dominant eye, the non-Duane eye, we may correct a certain amount. So the evaluation with prisms may help a lot to see if you really need to do so sophisticated surgeries. Your case was right, you had a huge upshoot, and that's what you decided. So the evaluation with prism also on the dominant eye help a lot to see if the patient may have surgery on the non-Duane eye to correct the exotropia, the head turn, without restricting the abduction. That was one of my comments. Mauro.
Dominique, first, I would say that I would have done the same first surgery you did. I learned 25 years ago from my first synergistic divergence patients that has a small movement of the affected eye to abduction. Mm-hmm. And when I operated on him, he was perfectly straight ahead, but he had no movement of that eye, and he complained a lot. And I think that the problem was myself, that I didn't explain exactly the goals of the surgery, that was correcting the anomalous head position, as you had in your case. But we have to tell the patient and the family sometimes which are our goals and our expectations. If they accept them, instead of turning his head to have binocular single vision, now that he has a constriction of his binocular single vision, he has to move his head more than he had before. So I agree with you. I try not to be aggressive, and I do what is on the book, and I'm happy with it. But congratulations for your first surgery. I think you did it correctly.
Yes, I think, if I may, The problem is that we have some very efficient surgical tools that to treat those cases. It is interesting for us to try to treat adduction and to keep the abduction active. So it is very interesting to think that we can do transpositions, but it may be too efficient and it may be very difficult. I think I would propose them only in children because it is easier for them to readapt to the new situation, and in very large cases. But I don't do those transposition anymore in not so big exotropia like this case.
Have a time for a question for me?
Yes, please.
Yeah, I thought that by transposing the inferior rectus, you might induce a V pattern rather than treat a V pattern. I didn't get this from Dr. Dominique, so can you please explain it?
It is, I discussed about that with Federico Velez, and really I re-asked him a few times, but really confirmed that when there is a V pattern, he preferred to transpose the inferior rectus and the superior rectus in case of A patterns. I don't like to transpose inferior rectus, and I don't do it anymore. I only transpose the superior rectus because this case was awful. It is really a bad souvenir for me, you know. I don't want to do it anymore. So I only transpose the superior rectus, which I have quite good results. And I don't think it is, I don't like the inferior rectus. I don't think it's a good surgical muscle anyway. So I think it's easier to perform surgery on superior rectus. And I am not sure it is the theoretical model to say that if you transpose inferior rectus, it will be better in case of V pattern is really true in the true life. I mean.
Thank you. And Hala, please. Yeah.
Thank you very much for the presentation. I have a question to ask. When you reoperated to undo the surgery, how much correction did you get by just removing the augmentation suture first? And couldn't that have been enough to improve the cyclotorsion that you got?
I wanted to go back to the first situation anyway. I didn't want to have another step. So when I took off the posterior suture, the eye went back a bit more. In the passive duction. It was the movement was better, but I didn't want to stay there. I didn't want to take the risk to. So I took off everything and I put the inferior rectus to the initial place.
Okay. Yeah, and I do agree actually that XT Duane, the results are less satisfactory to the patient than ET Duane.
Yeah.
I think always because of the limitation of abduction. Thank you.
Okay.
Thank you.
So if there are no more questions, shall we go to the next case? So the next case will be presented by Dr. Ahmed Awadein. Ahmed is a very dear colleague of mine, and he graduated from Cairo University Medical School. While you put up your slides, Ahmed, I will introduce you. He graduated in 1996, and he finished a fellowship in pediatric ophthalmology and strabismus at Johns Hopkins in 2006. He's a professor in Cairo University since 2014. He's the Secretary General of ISA-EAPOS. He's a great multitasker, organizer, and researcher, and a true inspiration for the young generation of ophthalmologists in Egypt. So,
thank you, Dr. Hala. So, my patient was a 40-year-old female. She presented with misalignment of her right eye. She had previous 3 eye muscle surgeries for correction of strabismus in childhood, with no reports of what was done in these surgeries. Examination of her ocular motility revealed a -4 limitation of adduction of her right eye. The limitation of adduction was present in both versions as well as on induction testing. Examination of her muscle balance revealed a large right exotropia of about 90 present diopters that increased on left gaze to over 100 present diopters, and there was also a small hypertropia on adduction of her right eye. So my plan was to try to restore the anatomy in the first operation. So I thought that I have to retrieve the right medial rectus muscle, which was probably slipped or lost, and I should combine this with recession of both lateral rectus muscles. And because the adduction of the left eye seemed okay, I decided to leave the left medial rectus later on for future surgery. And I counseled the patient that you are probably going to need a second surgery later on for fine-tuning. And this is exactly what I did. I retrieved the lost right medial rectus and did a recession of both lateral rectus muscles. And now you can see that there was an improvement of adduction of the right eye. But you can notice that the patient now has a small right hypertropia that increased gradually on looking to the left gaze. You can see that before the first patient, the patient had the hypertropia only on left gaze, but now the hypertropia can be seen in the primary position, and it can also increase in left gaze. Examination of her muscle balance revealed a right exotropia, a residual exotropia of 25 present diopters, with a right hypertropia of 20 present diopters that increased on left gaze. Her head tilt test also showed a small increase in the right hypertropia on head tilt to the right side. So my plan was for the residual exotropia is to explore the left medial rectus muscle, and I didn't know was it operated upon before or not. And I should have explored it in the first surgery, which I didn't do. And luckily, I found that the left medial rectus was recessed 7 millimeters. So I advanced it back to the original insertion, and I thought that this would be enough to correct the residual exotropia. Now for the vertical deviation for the right hypertropia was increasing when looking to the left side on adduction. So I thought that probably I should go with a right inferior oblique myectomy, especially that there was an increase in the hypertropia on head tilt to the right side. So I thought that this would be good for a right inferior oblique myectomy. But something felt wrong, so I kept the patient in the recovery room after the operation, and I told her that we might need later to adjust the surgery when she recovers from the anesthesia, when she's fully conscious, I mean. Immediately after the operation, sorry for the bloody tears, the patient had an improvement in the exotropia, but still almost no change in the hypertropia. You can see that the hypertropia is still unchanged. The patient has a right hypertropia of about 20 to 25 present diopters in the primary position. So what did I miss? The patient had a small A pattern, which is not consistent with an inferior oblique overaction. Usually you expect to get a small V pattern in those patients. And the patient had no extorsion of her right fundus. And I did see this before the operation, but I just skipped this point. So I talked to the patient and discussed with her that we might need to do something more before going back home. And luckily for me, she agreed. So I went back, put the patient one more time on the same day under general anesthesia, and I did a force reduction test to find an extremely tight right superior rectus muscle. So I went back and performed a right superior rectus recession of 8 millimeters. Post-operatively, initially the patient was annoyed because of the discrepancy in the size of the palpebral fissure. Notice that we weakened both elevators of the right eye. That's why you have widening of the palpebral fissure on the right side, and we did an advancement on the left side, so we have a narrowing of the fissure on the left side. But after 6 weeks, the discrepancy in the size of the palpebral fissure improved, and the patient had a reasonable good alignment in most gaze positions. This is appearance before the first operation, and this is after the first operation, and this is after the second surgery. So if I could turn back time, I should have remembered to explore all possible muscles in the first operation to minimize surprises. I should have also performed a force reduction test on all possible muscles. And the presence of a small A pattern and the absence of fundus extortion should have drawn my attention that I should not attack the right inferior oblique muscle. Now the question remains, why did this patient have the right hypertropia that showed only on A deduction, not an abduction? Was it a long-standing superior oblique underaction with secondary contraction of the right superior rectus muscle, what is known as the Jampolsky pattern? And did I need to weaken both the right inferior oblique muscle and the right superior rectus muscle, or was the right superior rectus muscle enough? Thank you.
Thank you very much, Ahmed, for the presentation. And you've posed really great questions at the end. So let me first try to pose these questions again to the panelists, and maybe they can come up with the answers. So the first question was, why was the hypertropia more in adduction than abduction of the right eye when the right superior rectus was tight and they should have been equal or even more in abduction? So any thoughts from the panelists on this? So Amr, do you have an answer for this question?
Well, it's difficult to get like exact answers for the questions, but I may have some suggestions. First, I would like to thank you, Ahmed, for this case. It's very interesting, and the way you followed it through. I would just say that I think you needed to do the inferior oblique anyway, because you had a positive Bilchowski head tilt test, and I don't think the superior rectus recession alone would have fixed that, even if you didn't have any torsion. The second, the thing that explains the hypertropia in adduction, usually when you have a limited adduction due to a slipped medial rectus, you may have more vertical towards adduction, and usually we don't fix that. I mean, if I have a patient that has no vertical in the primary position and is a limited adduction due to a slipped medial rectus, and I have a hypertropia towards this adduction side, we don't usually do that, and we believe that the medial rectus, correction of the medial rectus slippage can correct that. So maybe the limited adduction can explain the difference in the hypertropia across the horizontal gaze. That's what I think.
Thank you. Dominic, would you like to add something?
Yes, it was a very interesting case. It's always difficult to come back and to analyze the cases that have been operated by other persons and you don't know what has been performed. Do you know if there was some vertical surgery that had been performed before on the oblique or on the vertical recti?
Well, at least in my exploration, I was not able to find any scars over the vertical or oblique muscles.
And did you test?
So I don't think she had before.
And did you test the left inferior rectus? That could explain also vertical deviation that was increasing on the left gaze.
On left gaze, no, actually I didn't do a force reduction on the left inferior rectus muscle. No, I didn't do it in the first operation because the patient had a unilateral fixation preference. She was also always fixing with the left eye, so I always had the impression that the problem is on the right side.
And no abnormal head posture.
No, she's not a fusing patient. No abnormal head posture. She's not a fusing patient.
And no fundus torsion.
No fundus torsion, both sides actually.
Okay. So I think you were right to do what you did.
Mauro, would you like to add your comments?
I would like to add two possible things that might bring this concomitant on the lateral gaze for the vertical deviation. One is the lateral rectus contracture that might bring a pseudo inferior oblique overaction. And the second is you can have an inferior oblique overaction contracture. So the diagnosis of those two conditions you may get if you had measurements on the up, right and down,
right and left,
right and left, down, right and left position. This will give you great information about the superior rectus contracture and inferior oblique also overaction contracture. And also during surgery, the Jampolsky maneuver of bringing the right eye down and out and making some horizontal movements, you can feel the superior rectus contracture at this moment. This is answering this question.
Thank you very much. Ahmed, do you have the fifth slide? And your fifth slide, can you put it up again?
Which one?
The fifth slide, the one with the motility after the first surgery? Because actually,
Okay, let me look at that.
If it's too difficult, actually, I think that when you examine the motility of this patient and you bring in dextro version, I think it's the fifth slide, and in abduction and depression, I'm sorry, if it's too much, the one before, yes, that's the, okay, right there. I think you can really see that in depression and abduction of the right eye, that the right eye does not come down. And to me, that would have been an indication of that probably there was superior rectus contracture here. And you can see that the left eye has almost like a pseudo superior oblique overaction because of the limitation of depression. And in my opinion, actually doing the Bilchowski head tilt when you think that there could be a contracture might be misleading. And that is why if I was the person doing the surgery, probably I would have done the superior rectus only and not do the right inferior oblique, because I think that doing a single inferior oblique surgery, unless I'm really, really sure that this is a palsy, you will usually come back to haunt me and I would have a left hypertropia eventually occurring. So that's my thinking. And Rosario, do you have anything you would like to add or?
Well, I do agree, and also with the comment of the possibility to have superior rectus contracture and inverse Brown syndrome. That is what Mauro was telling before. If you look down and in, also the left eye, the right eye goes down. And that happens sometimes after previous myectomies. So, and I have another comment. You know, when we have such large exotropias, sometimes we have some verticals that when we align them horizontally and we take all the restrictions of such vertical surgeries, maybe change a lot. So sometimes we have huge deviation like this, that once we correct the horizontal deviation, you don't need so much vertical surgery. But of course, that's why we present the case, because it was a complicated case and we will turn back on a different way. But sometimes we have those cases that only with horizontal surgeries could be aligned.
Mm-hmm.
Okay, so in terms of time, let's skip to the next case. So congratulations, Ahmed. It was a very, very, very interesting case. So the next speaker, while you upload, Chong Bin, is the Dr. Chong Bin Tsai from Taiwan. He lives in Taipei. He's an assistant professor at the university and also special assistant and superintendent at the Chiayi Christian Hospital in Taiwan, and also has many different positions in councils. He's in an ISA counselor, very active, and also he's the president, for instance, of the Taiwan Agency for Prevention of Blindness. So if you unmute and go ahead.
Yes, I'm on. Yes, can you hear me?
Yes, please.
Sure. Can you see my slide?
Yes.
Okay. Thank you for inviting me to the ISA Egyptian Association of Appeals webinar. I would like to present a case of recurrent hypertropia and esotropia of partial cerebral palsy. This young lady came to my office with a complaint that she has esophageal deviation since 15 years old, and he feels occasionally vertical diplopia. And from the oculomotor examination, we can find that she had esotropia 30 prison chapter and right hypertropia 14 prison chapter. And here is the -3 adduction deficient and -3 depression deficient. And Madosra didn't show right in cyclotogen of 5 degrees. And this is the MI in 2016. And at that time, I didn't notice any muscle atrophy. So at that time, I performed the bilateral lateral rectus resection and right superior rectus resection. And after the operation, the first week it seems good, but for after 1 month, the right hypertropia recurred, and after 2 months, the right hypertropia became worse, and after 2 years, the hypertropia became 25, even larger than pre-operative, and after 4 years, there's a right exotropia 45 prison rupture, and at 5 years, and there's the esotropia 60 and right hypertropia of 60. So we can see in the video the limitation in adduction and depression. So I repeat the MI, and this time I noticed that there may be something that actually. So we take a look at the posterior cut, we can see the asymmetry of the muscle, but in the anterior cut we cannot see it. So in 2021, the MI, I think that's a muscle atrophy. And so this is a kind of case of there's a paralysis of medial rectus and inferior rectus and inferior. Because the Cerner maintained the topographic orientation even in the windband, so the lesions along every flare can cause divisional nerve palsy. And the inferior division of the Cerner innervate the medial rectus, inferior rectus, and inferior. So patient will present with exotropia, hypertropia, and encyclotropia. And treatment about the paralysis inferior division of oculomotor palsy, I only found one paper reported by Dr. Kushner. She reported his result doing the surgery proposed by NEP. That's the transposition of the superior rectus to the border of medial rectus and the lateral rectus to border of inferior rectus. And if the muscle have been already recessed, you just keep the same distance and follow the spiral teres to maintain the position, and also do the esotenotomy and well to correct the inside protrusion. So follow the NEP procedure. I perform surgery. First, I do the right superior oblique tenotomy with the 5 millimeter bridge suture, and then I perform the right superior transposition and maintain the distance from the limbus, that because I already have recessed it. And you can see that before transposition, I do some marking on the cornea, and I'm afraid that because rotation of eyeball, I will lose the orientation, so I mark it on the eyeball before transposition. And then that's a superior rectus, and I transposition to border of medial rectus, and the lateral rectus transposition to the inferior rectus. So this is correct. And during the transposition, I pay special attention to make them align the meridian, so to keep the balance of the muscle power. So after the operation, I found there's still a residual right esotropia and right hypertropia. And so I think, how do I adjust? Should I strengthen the transposed muscle, or should I weaken the transposed muscle? So I decided to strengthen it. So I advanced the muscle and come out to be the worst. there is more esotropia and more hypertropia. So to my surprise, so I need to weaken it. So I weakened it that the total handbag became 9 millimeter and 11 millimeter. And after the second adjustment, there is less esotropia and less hypertropia, but still undercorrected. So after the second operation, you can see after 1 week, 1 month, and 3 months, there is still residual esotropia, but the cosmetically is better than compared to before the second operation. So we can see that the paralysis of the inferior division of oculomotor nerve is rarely reported. In a series of 54 cases of oculomotor palsy reported, there's only 1 inferior division palsy, and only 25 cases have been documented. And there are various etiology reported. A patient had esotropia, hypertropia in cyclotogen, and there is no pupil involvement, no ptosis. I think it should be more frequently encountered, but it can be easily overlooked, especially when the hypertropia is small. And treatment is that I mentioned only 1 paper mentioned. But if we review the paper more closely, we can see that in Keshner's first case, there is esotropia and hypertropia, and he performed the INR and then recurrence after 1 year, and nearly the same amount with the pre-operation. And so he do the net procedure. And then we can see that there are 5 cases in Keshner's report. 4 cases were undercorrected. And even in the case 2 and case 4, she had to increase the recess 1 or 2 millimeter, but still undercorrected. So I think he's be in the same situation with me. So I think the net procedure maybe tend to undercorrect it in this situation. So why undercorrection? And my assumption is that if when you transpose a superior and lateral, when you as I do when I straighten it, more undercorrection. So it's pulling this way. So I think when we transpose the superiors and the laterals at this place, we still at the proximal side of the central rotation. So when we straighten it, it can turn it back. So if I can transpose the muscle to more digitally, I mean to the digital side of the central rotation, maybe I can create a force to adduct and infraduct the force when I straighten it. So if I could turn back time, I want to transpose the superiors and laterals to underneath, even extending the insertion of medial rectus and inferior rectus. Therefore, after operation, I have the possibility to a bidirectional adjustment. If overcorrected, I can weaken the 2 muscles. If undercorrected, I can strengthen it so they can rotate to the group more inferior nasally. That's what I think, but this case is not so often encountered, so I need to wait for another opportunity. This is my report. Thank you. Thank you.
Thank you very much, Chong Bin, for really this very, very intense discussion about the fact of how to resolve your overcorrection. And thinking on that, another possibility could have been a nasal transposition of the lateral rectus, but just inferiorly. I did that once, and I remember that Michael Greff, which is the one that in Europe is the big group of splittings and nasal transposition, he showed me how to transpose the lateral rectus inferiorly to the nasal medial rectus. But the problem is that when they are operated on, it is difficult to evaluate the tightness of the muscle. But that could be also a simple way to transpose the lateral rectus on the inferior rectus, nasal to the to the medial rectus, and you could get ISO effect and inferior effect. That could be. But that was just a comment. Arm, can you unmute? Yeah.
Thank you for this very interesting case. And Dr. Liano, the technique that you just mentioned, I tried it once, and I was advised to do it and move the lateral rectus only to the medial. And we put the superior rectus on adjustable to use it to titrate the dose of the amount of adduction and hypertropia that we get from the lateral rectus. It actually went well. I mean, in one case only, and as you said, it's very difficult to predict the results that you get from the lateral rectus transposition in this case. So you really need to have something else to adjust to oppose its effect, and that's when the superior rectus can come in handy in these cases.
Mauro, would you like to add? Thank you very much.
I want to ask Chong Bin. There were too many numbers on your presentation. Am I correct? On your second surgery, where you had the right hypertropia, did you advance the superior rectus? Was it on your slide in your second surgery?
No. Can I share my slide again?
Yeah, because I think I read it that you advanced a superior rectus when you had the right hypertropia.
Yeah, can you see the slide now?
Yeah.
Yes.
Can you see the slide now? Yes. After operation, I follow the lab procedure. So I transpose the superior rectus and right lateral rectus. And because before transposition, I measure the result of the prior operation. That's 40 millimeter from the burst. So when I transpose, I keep a possibility of bidirectional adjustment. So I make a 6 millimeter hand back. So that's a total 40 millimeter from the limb burst. And for the lateral, that's the same. So I mean that when the first adjustment in this situation, that's the residual hypertropia and exotropia, I try to strengthen it. So I advance that. But after advance, the esotropia and hypertropia become worse.
This is what I'm asking you. Yeah.
Yes.
This was expected, right?
Yes, and then I need to weaken in more, even more than my hand back. So that's reduced back. So I'm surprised that in this operation, I have no way to adjust. So I think that's because the procedure is always under corrected, and so I think it's not enough to on the other side to rotate the eyeball. So I think if I transpose it more inferior nasally, I have the possibility of bidirectional adjustment. That's what I think.
Thank you.
Mm-hmm. Okay.
Sorry, I was confusing numbers.
So I will give you the word, Hala, for the last question, and then I will pass you to the next moderator.
Actually, two questions for Chong Bin. Would you have considered adjusting only one muscle at a time and seeing the effect rather than doing the adjustment on the superior rectus and the lateral rectus at the same time? So, like, for example, advancing the superior rectus and seeing how much effect that would have? That's my one question. And the second question is, would you consider, I know we don't want to operate on more than two muscles, doing application on the medial rectus? Would you consider that would have helped you in any way to improve the adduction of the eye?
Okay. Yeah, I didn't adjust a muscle one by one because I think I just two muscle in the same time, so I can see the trend, the change of the position. If one direction is okay, the other direction is not, then I can adjust it back because I can do multiple stage of the adjustment. The second, I studied to placate, and I think is atrophy or hypertrophy muscle, because in the long run it will become loosening again. So I don't think the plication maybe have a short-term effect, but in the long term it will still drift back to the same position. That's what I think.
That's just because when I looked at the table with Dr. Kushner's results, the ones that really had the better results were the ones that had already done an R&R before. They've done a recess resect. So I thought maybe that would be helpful. Thank you. Thank you very much. So we'll go on to the next speaker. It's Dr. Amr Elkamshoushy, and I'll introduce him while he shares his screen with us. So Amr graduated from Alexandria University in 2001, and he completed his fellowship in pediatric ophthalmology and strabismus at Indiana University, 2009. He is an assistant professor of ophthalmology in Alexandria University and a board member of ISA-EAPOS. Amr also is extremely passionate about scuba diving, and he has scuba dived all around the world. He's gone to Brazil, Spain, and Taiwan, and many other countries, and is very passionate about that.
Thank you, Dr. Hala, for this introduction, and I will dive straight through. I like actually the title, If I Could Turn Back Time, made us think about a lot of the problems that we had with the cases and everything. So this is a case of an overcorrection after transposition surgery. The cases presented so far all had some happy endings. Mine did not have a very happy ending, and let's see how it goes. So this is a case of a 28 years old male patient. He had a history of strabismus since childhood. He gave a very vague history of some cranial surgeries. He was really young and he didn't have his parents around. But as far as we can detect from what he said is that this was a trauma, and he had a bilateral third nerve palsy after this trauma. His MRI didn't show any abnormalities. This is how he looked like when he came to us. And he gave a history of a strabismus surgery a few years back, a left lateral rectus recession. As you can see, there's a large exotropia, limited motility in all directions. We decided to proceed with doing nasal transposition of the lateral rectus. We split the lateral rectus and we transpose it to the medial side. We did it simultaneously in both eyes at the same time. He agreed to do that. And our usual technique, we do it with the superior oblique tenotomy. And our usual technique is that we do it not on adjustable, we do it with fixed sutures. So 3 months after the surgery, we have a large esotropia of 45 prism diopters. His motility is restricted in all directions, and the patient has a diplopia that is intolerable, and he's not happy at all with his double vision. Anyway, so far, nothing seems a problem. We thought we can fix that. We took him back to the operation theater. We did force reduction test. There was resistance in abduction in both eyes, so there was limitation. We dissected and found the split halves of the lateral rectus. They were identified. I disinserted them, held them on sutures, and I thought then I would have a free force reduction test, but I did not. After I did that, the eyes were still restricted. So I just cut off these halves of the lateral rectus that I transposed. I let them set them like free. I cut them freely, and I thought like with time, the eyes are going to drift back outwards again. 4 months later, little have changed. The ET is 40. There's still restricted motility in all directions. The patient is unhappy. He still has intolerable diplopia. So we waited some more time and took him back to the operation theater. And this time we were aggressive with the surgery. I did force reduction test, again, resistance to abduction in both eyes. So I just dissected everything on the medial side of the globe. I cut the medial rectus. I cut all attachments that are confined on the medial side of the globe until I found like only the sclera from the limbus as far back as I could reach. I even went back to the lateral side to make sure there's nothing attached on the lateral side. It looks really scary in the surgery with all the muscles cut off on the medial side and the lateral side. But I thought, I mean, at that point, even at the end of the surgery, the force reduction test was still restricted. But I thought like with time, the eye is going to drift outside to the natural position in the orbit, and it's going to have some exodeviation. And 9 months after the surgery, the patient still had esotropia of 40, restricted motility in all directions, and double vision. At that point, I was treating him with occluders, and he used a high plus power contact lens in one eye to manage his double vision. It was a very silly situation at that point because I have done everything that I could do. I mean, there is no more muscles to cut. There is nothing attached to the sclera on that side. And I thought the only thing that could help the patient at that time is a time machine. If I have a time machine, I would go back in time and maybe do it differently or not do it at all. But since we don't have a time machine, the only thing I could do is learn from the mistakes so as not to do it in the future. So that made me think, like, where did I go wrong? This is how this is the summary of his story. He has an exotropia. We did the transposition, and then after that, we did 3 months later, we cut the transposed halves, and then we tried to dissect and everything. And where exactly could I have saved the day? I believe that I went wrong here. That's the first place. I did the second surgery 3 months after the first surgery. I believe if I did this second surgery early, 1 week, maybe a few days after the first surgery, the eye would have went back to its exotropic position. Maybe I would have got some correction. Because it seems that the way fibrosis develops in these cases is different from other strabismus cases. The orbital anatomy changes with time, and these changes becomes permanent, and moving the muscles back does not bring them back. This is the expected anatomy in the post-operative anatomy in the cases of lateral rectus nasal split transposition. And I believe now that the fibrosis happens around this part of the globe. It happens way posteriorly where we split, because in my case, I'm sure that on both sides of the sclera, on the medial and lateral, there was nothing attached there, and yet the globe was held in its adducted position with a positive force adduction test. That means that the muscles are no more holding it. The fibrosis is way posterior where we cannot see it. The second place where I think that I went wrong is the surgery itself. I'm not a big fan of adjustable. I rarely do adjustable, maybe 3-4 times a year. You know, we have people on both sides of the aisle regarding adjustable surgery in strabismus. And I'm on the far side of the people who rarely do adjustable. But in this very particular situation, that is where I would do adjustable surgery. And I do these cases adjustable since I did that case, now I do them all adjustable. Because that is when you want to adjust the case in the immediate post-operative or maybe in the first day, because whatever you get after the first 2-3 weeks, I don't think you can change that. And there was even an added level of difficulty here that this patient did a previous lateral rectus recession. So the lateral rectus was tight when I was moving it, yet I did a lot of effort and I moved it to the medial side. Maybe it was too tight and that's what caused an extra esotropia. But if I had it in adjustable, maybe I could have changed it. So I believe, but mainly I think that the timing of the reoperation is the key here. And if I could turn back time, I would do the reoperation in the first few days in these cases. And this was not our only case. This is another case which we did. This patient had a large exotropia, and actually his verticals were the superior and inferior were functioning. And we did him a transposition of the superior and the inferior, and he got an overcorrection. And as you can notice, the child grew old, and then 1 year later we undid the transposition, and again the eye stayed in the adducted position, and it was not improved. We looked at similar cases. This is a paper published recently with our group. I have Dr. Hala Elhilali and Dr. Ahmed Awadein and a colleague of ours, Dr. Dina Hassanin, with us. It's published in 2021 in Eye, and we looked at overcorrection after vertical muscle transposition for cases of 6 nerve palsy. And again, we found the same finding that in the cases in large overcorrections, if we re-intervene later than 3 or 4 months, there's always the exotropia still stays, even if we undo the vertical muscle transposition and we bring the superior and the inferior back to their normal positions, to their original positions, the eye still stays in exotropia. So if we have an esotropia due to 6 nerve palsy, we do a transposition, it's overcorrected, you have an exo. In these cases, I strongly advise we go back and fix them soon after, within the first 2 or 3 weeks, maybe the first 2 or 3 days if possible, so as not to get a permanent overcorrection. And this is my last slide. If I looked at the literature, Kushner published in 2018 about reoperations, that reoperations should not be done prior to 6 to 8 weeks. I think that's what all of us do. We do our reoperations 2 to 3 months after the surgery. Kushner said the most important exceptions include a suspected slipped or lost muscle, a large overcorrections after a tuck, and the hypertropia of more than 5 prism diopters the day after the vertical muscle transposition. He thought that these surgeries, kind of undoing them later on, does not give the effect on the motility. And to this we add that overcorrections after nasal transpositions of split lateral rectus and large overcorrections after vertical muscle transpositions are surgeries that should be reoperated early, not late, like in 6 to 8 weeks as we usually do. This is what I learned from these cases that I did. Thank you very much.
Thank you very much, Amr. It was a very good presentation, and I'm sure all of our speakers have their own experience with overcorrection, and I'm hoping that they would share their concepts and ideas with us now.
May I have a question? So based on your experience, where would you like to leave your patient after a nasal transposition of the lateral rectus? Which deviation and how much tight would you like to leave it?
With these cases, when I first started doing them, I thought like it's good to leave them in esotropia of 10 to 15 prism diopters because you usually expect them to return back to the position. But as I did more and more of them nowadays, a lot of them just stay where you leave them. So if I could do them, leave them aligned or even leave them or less than 5 prism diopters of esotropia, that's where I leave them. So no, I don't go for 10 or 15 prisms of ESO. I expect them to stay where I left them. So if I can put them aligned, that's my target. And regarding the limitation, no, I don't think any of these patients have any ocular motility. And that's what I tell my patients before the surgery, that do not expect the eye to move at all. That's not a factor that they take into consideration. Just want the eye to be straight in the primary position.
Dominique?
Yes, thank you. This was a very, very interesting presentation because you have a nice experience. This is not surgery that we do quite often. I have done a bit of them, and 2 of them were made on adjustable suture, and it was quasi impossible to adjust at day 1. So I think really, just as you say, I think it's better to leave them as they are going to be after that. They don't move too much after surgery. So how were they at the end of the transposition surgery? He was in ESO position.
In the end of the first transposition surgery, they were in a bit of an ESO position, but it was not as bad. I remember that day in the surgery, it didn't look as bad in the operation theater as it looked afterwards. I didn't have an early picture of the early post-operative, but I believe that this patient worsened over the first few weeks after the surgery.
And you said that there had been a previous lateral rectus recession on the left eye, I think.
Yes, there was. Yeah, there was.
And the lateral rectus was smooth enough to transpose to the medial rectus, because usually when it has been already recessed before, so it is difficult to do the transposition, the Y splitting.
Yes, I totally agree with that, that if the lateral rectus is recessed to a big extent, like if an 8 or 9 millimeters recession, it's been done long time ago, and you have a tight lateral rectus, the surgery can completely fail and you're not able to move it. And I say that to my patients, because sometimes I get a patient of a third nerve, and he has a history of a previous surgery. And I know what this surgery is. When I take them to the operation theater, I tell them the following. If I find the lateral rectus in place or had a small recession, I will be able to do the nasal transposition. But if I find the lateral rectus at an 8 or 9 millimeter recession, I will close the conjunctiva and I will not continue my surgery, because it gets very tight, it cannot be moved to the other side. And I got my patients fair and square on that I may not proceed. In this particular patient, I said the same, but I was able to move the muscle.
So maybe adjustable suture is difficult to perform because I think the lateral rectus is stitching to the globe at the posterior part, just as you showed on your picture, and I think it stitches to the globe very early. It is maybe why it is impossible to adjust that even at the day 1. So maybe if there is an overcorrection like that, it's better to. I have not the experience about that, but to take off the lateral rectus and to try to put it back to its initial place, but early after surgery, maybe.
From my experience, I mean, when you do it adjustable, you can correct an overcorrection, but not an undercorrection. Look, I'm not a big fan of adjustable. As I said, I don't do a lot of them. But what happened in the cases that I did after that? If I find an immediate post-operative esotropia, I can correct that and restore the patient to primary position, even a slight exo, but not the opposite. I mean, if after the surgery in the adjustment, you have an exodeviation, it's very difficult to pull the muscle forward and achieve an esodeviation in the adjusting.
Thank you.
Chong Bin, would you like to add a comment?
I think the time is not enough. Because I want to ask, when you transpose the lateral rectus, where did you put the transposed muscle at the insertion of the medial rectus or behind? Because I have report probably one paper that is already operated lateral rectus. I used the fascial lata to augment the length, and I found that the amount needed to augment the length of the lateral rectus is around only 5 millimeters. So when lateral rectus have been recessed, and so there is some kind of lateral contracture, and not so much. So if you try to transpose already recessed lateral rectus, if you can spread in it very good and make a very long enough height, probably you may not transpose it to the insertion of the medial rectus. Probably you can more posterior because some kind of contractual lateral rectus. That's my opinion.
Thank you very much. So we move on to the last talk.
Yes, and
the comment, Rosario?
Yes.
Just a final comment. In 2018, I was invited to give a lecture at the ISA-EAPOS meeting in Washington. And the title was Treatment of Third Nerve Palsy. And I remember in one of my slides that I presented on the nasal transposition of the lateral rectus, I said that although it is a new technique, it doesn't mean that the old techniques are not good. So maybe the lateral rectus transposition is not the best treatment for all patients. So I'm not giving this consideration to your case, Amr, but I would just remember that we have other techniques that we can keep using them.
Okay, thank you. Would you like to answer, Arm?
No, thanks. No.
We
Thanking them for the comments. No,
so Mauro, if you can upload your talk. So next speaker is going to be Dr. Mauro Goldchmit from Brazil, Sao Paulo. He will speak on consecutive cyclic esotropia. He's also a very well-known person in the world. He's an ISA counselor. He's a professor of ophthalmology at the University Sao Paulo, and he's chief of the Department of Strabismus at Santa Casa, and he's the executive director of Strabos Institute. So Mauro, please.
First of all, I would like to thank ISA-EAPOS and ISA, Rosario and Hala for inviting me to participate in this webinar. And I will present my case, which is a 7-year-old girl that I first saw her in January 13 this year. She had a history of a surgery for intermittent exotropia, an RNR on the right eye in October 21. And immediately after surgery, the report I got from the surgeon was that she was ET2 for distance and ortho for near, which is a good result. In November 21, she started presenting a sclerostaphyloma on the temporal side where the lateral rectus was operated on. I talked to the surgeon, which was a former fellow, my former fellow. It's a good surgeon. He said that surgery was uneventful. And here we see surgery was in October, and she started presenting this staphyloma in November. We can see what happened in January, and this a few days later. So in December, she presented ET25 and diplopia. And in January, she came to see me complaining of ET and diplopia with a normal neurological examination and a normal brain MRI. You can see a small degree of astigmatism in both eyes with good vision. And at slit lamp, we had this sclerostaphyloma. And on motility, she was orthophoric with normal stereopsis and normal versions and ductions. Here we see the staphyloma. And here we see her with the eyes straight. So I followed her every 3 days. She lives in a city about 2 hours from my office. And my concern was the staphyloma. And we were preparing, that was enlarging, and we were preparing for a sclerograft. When we start seeing this white tissue here, and we decided to wait to take any surgical procedure on the sclera. We ordered an MRI that identified here on the lateral side and on the medial side also a thinning of the sclera, either temporary and medially. But parents were telling me that she wakes up with ET, complaining of diplopia. She needs to wear a patch and the deviation disappears by the end of the day. She was with the patch and she was saying, now I can take it because I know my eyes are aligned. So I asked them to send me pictures in the morning and evening, and they gave me permission to share the photos for discussion. So and that consultation, she had an esotropia 25. And here we can see several photos at 10 a.m., 7:30 p.m., 9:30 p.m., 9:58, sorry, here is a.m. and here is p.m. You see deviation, ortho. Sometimes deviation disappeared not in the afternoon but or evening, but in the morning. But again, 9:30, 9:40 a.m. and p.m. And again, this was in February. And some photos now in April. Again, morning and afternoon, morning and after lunch. So we have a 7-year-old with a consecutive esotropia and diplopia with a cyclic pattern that is about 12 hours, some days less than 12 hours. So the title of this webinar is If I Could Turn Back Time, but I want to change the title of the presentation. Before I have to turn back time, I would like to hear your comments because I never had a case like this. I posted on the PedOpt list on the internet, and I got 3 answers. One was to check with a uveitis person, and I checked with a specialist in uveitis and also a rheumatologist. Nothing was said, and I was asked if the surgeon has done too much cautery, and he said no, normally nothing more than I usually do. And one colleague said, why don't you go back to the lateral rectus, advance it, and cover the staphyloma? I'm really afraid of going back to that region of the eye with that staphyloma. So my concerns, have you ever seen a case similar to this, and would you do something for the sclera now? And the second question, is this consecutive esotropia related to the sclerostaphyloma due to a discontinuity of the sclera that avoids the normal lateral rectus traction to abduct the eye, and it favors the medial rectus to pull the eye to esotropia? And how to explain the cyclic pattern of this esotropia? And if you would operate on her, if you say yes, would you do an R&R on the left eye? Can this happen on the sound eye now? Would you advance the previous recessed lateral rectus? And any other idea is very welcome. And I would like to thank you with some pictures of myself in Egypt almost 40 years ago. Thank you very much.
Yes, one of my colleagues just sent me a photo of a patient that she did. She actually had exactly the same. She did her bilateral lateral rectus recession, and the patient developed a clear staphyloma. But the difference, the staphyloma was more posterior. It was exactly where the sutures were placed. So she thought this was probably induced by the Vicar sutures. It was like a kind of necrotizing scleritis induced or a reaction induced by the sutures. So I was wondering if the patient had a hangback sutures or this was the original insertion of the muscle, no sutures were placed like that. And the second thing,
hangback.
And the second comment that I noticed that in the photos that whenever the patient tries to align her eyes, she always adopts some chin down position. So sometimes the patient have like a small consecutive V pattern that the way for them to compensate for the consecutive esotropia.
No, that I am aware, and know that the parents told me about any chin down position.
Is the abduction full in this eye? Is there any limitation of abduction?
No, no limitations on abductions and inversions.
No difference when she's in ESO or when she's straight. The motility is the same.
But it is the same, yeah. Yeah, I checked her in different days that she is ortho and days that she is with ET, and there's no change. The point is that she wakes up with diplopia, she has to go to school and leave the whole day with the eye patch, and only in the afternoon, most of the time, of the days, only in the evening that the eyes are straight, and then she goes to sleep. So she, almost all the day, she has one eye covered.
Is there a difference between the far and near angle, or are they the same?
No, the same. No incompetence.
Well, it is very nice because we have two cases in one. For once is how to do, which is the cause of the staphyloma, because sometimes we have some type of meltings on the postoperative days. If you have exposure and you have dry eye, and that may improve only with artificial tears. I also consulted the case. I copy your case, and I discussed this morning with my team, and they said also that that's not related to any immunological thing. They wouldn't think about. And also I asked them if they will suggest to cover it with any exclera in order to make it more safe or more beautiful. And they told me that if we do an sclera explant, we should do it very thin, because if not, it's going to be awful. And we should cover it with conjunctiva or amniotic membrane. If you want to cover all this black part, that it is risky and maybe also ugly, how to say it. Yeah. That is one thing. Do you wish any more discussion about the etiology and the management of the staphyloma before we go on the cyclic? Because you place two cases in one.
Whatever you want. If you tell me that a sclerograft is an option, we are considering it, because I'm always telling the parents that there is a risk to leave the eyes with this staphyloma. But the other question is what to do for her deviation and the condition of diplopia.
So for the next thing, it will be maybe a Botox, will be a trial of Botox, because maybe the same thing may happen on the second eye when you go back again or when you reoperate. So it is a simple technique to try, which maybe is not the best case because it's a cyclic and they are very little experience on cyclic but it's not a pure cyclic. We have some strange cases that have been published after recession surgeries. I had one after a Yokoyama technique that I had a cyclic case, but there were also rare cases, not the 48 spam. I also tried melatonin in those cases, and also I think there are some references without any effect on on the. So I will try a Botox maybe first, if.
Very good idea.
Yes.
Yeah, very interesting. I was just taking those moments to think about it. Maybe the staphyloma is not related to the esotropia. So what I would think is, let's first you would do the scleral graft because you want to protect the eye from vision-threatening complications, and then take your time to think about the esotropia, because the staphyloma is really dangerous here. And regarding the cyclic esotropia, the interesting part about it is that it's very regular. Usually in case of consecutive esotropia after an exotropia surgery, sometimes they're not the same all the days. Some days are good, some days are bad. I mean, regularly we get the complaints from the parents saying that towards the night when the child is sleepy, they see the esotropia more. But what's intriguing about your case is that it's very regular. It's a fixed time in the day. And I think that maybe it's going to progress into esotropia, into like regular consecutive esotropia, and then you can undergo surgery. So my suggestion would be that you would go back for surgery and do the scleral patch graft, because you want to play it safe and you don't want to take any risks with the staphyloma. And while you're at it, you can inject the Botox in the medial rectus. Yes, I mean, it's not a very good idea to touch the muscles again here with the staphyloma that happened, and we don't know the cause of the staphyloma, but the Botox will be very safe, and wish for the best. Maybe that will fix the esotropia.
I share the photo I have with the staphyloma, the other one.
Yeah.
This is the patient. She had lateral rectus recession, and you can notice a large bulk of staphyloma in a patient similar to Dr. Goldchmit.
Ahmed, I've seen something like that, and it turned out not to be a staphyloma. It turned out to be a cyst that had blood.
Chocolate cyst. Yeah, but this was not a chocolate cyst, actually.
Yeah.
But it's actual clear setting. Yes, I understand.
Did you actually do surgery for it and put a patch graft?
No, not yet.
So Dominique, and
Yes,
then I will give the word to Hala so she can ask and close the symposium.
I'm not sure there is a relation between, as none of us are sure there is relation between the staphyloma and the cyclic esotropia. But I think if you are anxious, you have to do the scleral graft. But for the esotropia, what I like to do when there are cyclic esotropia is to do a prism test on the esotropia part, and you see if it stays stable. Usually it worsens with time, so it becomes a permanent esotropia. So if you are in a little hurry to know what's going to happen, you may be doing a prism test with a prism that corrects the esotropia that is present in the morning, and you see what happens. Maybe she won't see double. She won't have to wear a patch, and maybe it stays correct the whole day. And then you know that there is a real esotropia and you can do surgery for that.
Okay. Thank you.
Actually, I found in the literature a case very similar to yours, not with the staphyloma, but with the cyclic ET after intermittent XT surgery and lateral rectus recession. And it's in the Indian literature, and I think Ramesh Kakunya is one of the people who published it. And when they reoperated that case, they found a stretched scar. Even though she had full motility and everything, there was a stretched scar on the lateral rectus. And I'm thinking maybe the staphyloma does have something to do with it, that the fact that the staphyloma caused the thinning of the sclera, it caused stretching of this area, because now you don't have that much sclera. And that caused the lateral rectus to move backwards because of that stretch. So maybe that could be related. I agree to do the scleral patch first and then wait and see if you can reoperate on that eye or do an R&R on the other eye if the esotropia gets worse. And does anybody else want to add anything? I would like to thank all of you. It's been a wonderful discussion. I've learned a lot from all of you. Thank you very much. And I would just like to announce at the end that the next International Strabismus Association meeting will be in September. from the 8th to the 11th of September. It will be in Cancun, Mexico. We're hoping that a lot of you will be able to attend, and we want to remind you that the early bird registration ends on the 30th of April. Thank you very, very, very much. Thank you, Rosario, for everything.
Thank you to you and to all the panelists for these very, very nice cases.
Thank you.